Can you tell us how you made your way into, or how you found your way into gynecologic surgery?
Yeah, so I was very interested in academic medicine when I was a resident, and I was interested in advancing knowledge and in practicing state-of-the-art medicine, as well as being around people all the time. I like the academic environment, the camaraderie, the ability to be around experts all the time. I was also, before medical school, I was an artist, so I like working with my hands. I like putting things together. I also like action, doing things, energy, activity, and figuring out discrete solutions to problems. And I think surgery really kind of let me put all those things together. I mean, it let me work with my hands. It let me find solutions to very real problems, things you can fix. And it also kind of, ultimately, I think medicine for me is about taking care of patients. And I think surgery was the way that I felt that I could do it best.
In your opinion, what makes a good gynecologic surgeon?
So I think it's what's in your mind that makes you a good surgeon, not what's in your hands. And I feel pretty strongly that, thoughtfulness, planning, learning how to be cautious, having humility, having empathy, understanding that you work for the patient and our job is to make their life better. I have a quote, it's probably one of my favorite quotes about surgery, which not everybody agrees with, but it's from Harvey Cushing, who was a pioneer neurosurgeon in the 20th century. It said, he said, "I would like to see the day when somebody would be appointed surgeon somewhere who had no hands, for the operative part is the least part of the work." So I feel that way very strongly, that it's not necessarily the technical part. It's what's in your head. It's your thinking about the problem. It's being prepared. It's making sure you're doing the right thing for the patient. It's learning how to know how to deal with complications in advance, so that when something happens unexpected, you've thought about it and you know how to deal with it, rather than having to figure out a solution on the fly, which doesn't work as well. So for me, it's really what's in the head, not what's in the hands. And everybody might not agree with that, but we've all experienced a very good technical surgeon who's not a thoughtful surgeon, who's maybe taking out things they shouldn't take out, or just doing it because it can be done. So I think it's really the mind that makes a great surgeon.
It's a great response. Thank you. I think we're definitely going to be using that response in our compilation. So the theme of this upcoming meeting in the spring is surgeons as change agents. What does that mean to you, and what changes have you seen in your career, and what do you have coming up next?
So that's a great question. So I mean, we're clearly more inclusive. So we're including more people in our specialty, and that, being inclusive allows people with different perspectives and different expertise to come in, so that we can find new and better ways of taking care of patients. But that also includes involving other specialties in our care of patients. So I mean, a big change that's happened, I think, in urogynecology over the last 25 years is non-surgical management of patients with the involvement of physical therapy. That's been a big advance. But urogynecology kind of developed because patients were getting fragmented care. So, way back when, a patient might be seeing a colorectal surgeon or urologist or a gynecologist, and each one was focused on their own area without thinking about either the other parts of the pelvis or the whole big picture, how it works together. So urogynecology kind of developed that, we were going to be the gatekeeper and we could kind of take care of all of it. And so there was a period where that was really an emphasis in urogynecology, that we were the gatekeeper of the pelvis and we could take care of all the different systems. But over time, and that went on pretty strongly for about, I'd say, 10 years or 15 years. But then over time, as we grew, other specialties became more involved in the care of these patients, often for the benefit. I mean, clearly for the benefit, but I think we have evolved a little bit back into a fragmented care of patients. I mean, we've all kind of seen the patient who's been in physical therapy for 2 years and has a huge rectocele that needs to be fixed, and nobody ever examined the patient to see that. So I think that's a little disappointing to me, because I think we do need to involve everybody, and that's how, and we're definitely benefit from other specialties being involved in pelvic floor dysfunction, but we need to figure out how to not to evolve back into a model of fragmented care for patients. I mean, patients don't necessarily want to see 3 separate doctors for their pelvic floor issues. So that's sort of a change I see, in something that's evolving over time. But the other thing is, I wrote down some notes on this. So I feel like, in some ways, with how the world has evolved and things have changed, some people now are looking at medicine more as a job than a calling. And I find that disappointing to me personally, because for me, it was a calling, and I was not so interested in necessarily it's 5 p.m. I have to go home, or it's 9 p.m. I don't want to take the call from the patient at night. So I feel like that's sort of a negative change that's happened, and I hope we kind of get back to the fact that, this is a noble profession. We're taking care of people, and it's really a life's work and something you need to be fully committed to, kind of 24 hours a day, although that's maybe not the politically correct thing to say, but that's how I feel about it. What else? I feel like we are really still learning how to listen to the patient, which has been a journey for us to figure out how to listen to what patients are saying and how to respond to them. And I think we're still figuring it out how to do that. We're getting better at it, but we're not there yet. We have to learn. We still have to do better at trying to listen to what patients are telling us is bothering them, and come up with solutions to fix what's bothering them, not necessarily what we can fix. And then the other thing I thought about with this question was just the whole way technology has advanced, and how that's changed everything about the way we practice medicine, including the electronic medical record and technology in the OR. Now with AI developing, we'll have to see how that evolves. I mean, but and also, the knowledge explosion that's occurred. So I think we have to, in a lot of ways, we're still kind of doing the same operations we were doing 30 years ago. So even with all that, a lot has not changed. And we have the robot now, but we're doing the same operation. We have laparoscopy, minimally invasive surgery, but besides not having the incision, we're essentially doing the same operations. So I think I personally feel like we lost a big opportunity, at least with prolapse surgery, when mesh. With the home mesh debacle, I feel like we have not necessarily figured out how to cure prolapse, and vaginal mesh, I think, has potential to help, but because of the way that whole thing rolled out, and in the poor way it rolled out, and putting it in the hands of people that didn't really know how to do prolapse surgery. I think we've been set back many, many years. So I think ultimately mesh may come back as a possible solution for like a vaginal approach to prolapse repair. And then I think the other thing is prevention is something that will have to improve over time. That's something we're not as focused on as we were focused on it a little bit, but not too much. I mean, we're surgeons. We want to operate. We want the knife to be the cure, but really prevention is really what's going to be the ultimate solution, I think. That was long-winded, Cecile.
No, that's okay. Don't worry. Again, it gets clipped, and so it'll look very succinct and not long-winded. But no, I think all of those, you're in good company. You have a mix of thoughts that sort of have been a lot. The responses are similar amongst those of you who have made these big contributions. I loved what you said about the very earlier about what it means to be a good surgeon, and that sort of also that embodiment of being a doctor, I think is really important. And of all the innovations, I said this in a talk once, somebody asked me to give a talk on innovation. And I said, I hope that we actually go back in time and teach people how to doctor. That's not like a fancy innovation, but we need to innovate how we convey that importance to learners and trainees now, right? That would be the innovation. I'm new to San Diego. I don't know. I left Cleveland Clinic and I joined the UCSD practice this past year. And so the residents don't know me very well. And we were operating, and towards the end of the day, I said, okay, once we recovered the patient, why don't we go round on all of our post-ops who are still here and make sure that their questions are answered. I like to see the patients right before they leave so that they know they're, and the resident said to me, that the nurses will call us if there's a problem, right?
Yeah.
And I said, well, what's the point? Don't you I said, that's what's so fulfilling, is to go just do a patient afterwards and tell them their surgery went really well. Right?
Yeah.
Right.
Yeah. I mean, it's a different world. I mean, the other thing that kind of in our practice, we see our patients back post-op and we keep seeing them. And I feel like I see patients every year. I try to see them once a year if I've operated on them. Now, it's true it clogs up the schedule, but I feel like the issues that we deal with wax and wane over a person's lifetime, and I'm not going to be able to have the opportunity to intervene if I don't know what's going on, how it's changing. So I feel like that's important for us to, as a specialty, to kind of take care of patients over a lifetime, not just operate and then say bye-bye. But that may not be that popular, but we do that in our practice here. And you see that, someone you operated on 7 or 8 years ago now has another problem, and it might have taken her 5 years to get back in to see me for that if she left it to herself, but because I'm seeing her frequently, I have the chance to maybe intervene early. Plus, part of the reward of being a physician is taking care of people. I think getting to know people, and that's really, for me, that's very fulfilling. I mean, I've had patients for 20, 25 years, and I find that that's a big part of doctoring, just taking care of patients.
Yeah, I also, Mark Walters and I are very close, and he's one of my mentors, and he's I consider him family, but we've spent a lot of time together. But we were partners before he retired. And one of the things in his practice, he did annuals for his patients. The patients he operated on, he would do their GYN annuals afterwards because they would ask him, and he said, of course. And it gave him the opportunity to also just follow his own surgeries and to really understand the natural course of native tissue repair. And so he did all of his own post-op care. And when the system started to change, right, when the recommendation was that you pass those types of patients off to APPs and that you should really just be seeing surgery consults, he then realized that his practice was no longer fitting the model. The timing ended up being right. it's interesting. And I think that there's this shared view of, again, what it means to practice. We're
Yeah.
not just cross-sectional clinicians, right?
Yeah.
There should be a
Yeah.
longitudinal experience. So
Yeah.
he'll appreciate hearing this. I'm interviewing him a little bit later this week.
Is he I know he was going to Costa Rica a lot. Is he still doing that, or?
Yes. So he travels in the winter time. So January through March. He
Yeah.
usually
Yeah.
makes his way back to SGS at the end of his Costa Rica trip. That's like that's what he comes back for usually. And then,
Yeah.
but
Yeah.
yeah, he was doing that in the end of his practice time. And then he's still in retirement doing that. So,
Yeah. Yeah.
so shifting gears, what role has SGS played in your career?
It's played a huge role in my career. I mean, I've gone to, I don't think I've missed an SGS probably since 1992. It's the meeting where you get to be with like-minded people. It has a fantastic camaraderie. You can advance your knowledge through discussion in the hallway that everybody talks about with colleagues. But also, for me, it's allowed me to sort of interact with like the great teachers in our field, and people like Delancey and Shull and Mark Walters, and these people are all very welcoming and um, you know um, very willing to share their experience with you. Um, and so I get to see my mentors there, and also your mentees as you get older. The people that you trained are there, but it's really like a nice mix of science plus practical knowledge. So I think the science is pretty good, and it's gotten better over the years. The discussion is really good, and then the practical knowledge that you get out in the hallway and at the coffee breaks is really not replaceable. Really, other meetings are just don't kind of have that same feel. And it's kind of a nice group of people too. And it's evolved over time. It's expanded, and I think that's good. I mean, it's expanded now to really include MIGS people, which gives a whole different perspective on it, but it still has the same feel that it had before. And it's really different from OGS, and for the MIGS people, it's different from AAGL. So yeah, it's really a good society and a good group of people. And I would say it's the one society that I've learned more from than any place else. Also, when we were starting the Fellows Network and the Systematic Review Group, SGS was very supportive of that and was really interested in kind of getting fellows involved in research and bringing them into the organization, as well as kind of with the Systematic Review Group using the literature to really kind of advance our practice. So I think SGS really took the lead in those areas, and that's been very rewarding for me.
You mentioned some of your mentors. Who were your mentors, or who are your mentors?
Well, I would say, one of my mentors was Andy Fantle, who was my partner when I was at Stony Brook, which you were there, right? Yeah. Were you a resident there?
I went there for medical school.
Okay. When were you in medical school?
2004 to 2008.
Okay. All right, I was gone by then, but yeah, Andy Fantle at the Cleveland Clinic when I was a fellow. Lester Ballard was one of my mentors. Um, Great vaginal surgeon, a really genuine person. Fantle was a big mentor and still is a big mentor for me. he introduced me to people. He taught me things. He taught me about research. And also, Bob Scholl was a big mentor for me when I came to Texas. I mean, he was very welcoming. He didn't have to be nice to me, but he was, extremely welcoming, and he helped me, and he helped when we started the fellowship at UT Southwestern. He graciously took our fellows to come down with them, and for many years, our fellows rotated with him for a month, which was a fantastic experience. So he was really a pretty great mentor for me. And then the other people that are around SGS, people like, that are my friends, but also mentors like John Delancey and Holly Richter. All the people kind of I've worked with over my career have really been, great mentors and friends.
I just before we did this interview, I was interviewing Deb, and she was talking a lot about Andy Fantle and how he is one of her mentors too.
And also Steve Young was a fantastic mentor for me, and unfortunately we lost him, but he was president of SGS and I was the head of the research committee. So he helped me, and we worked together a lot. And that's when the FPRN and the SRG started. So he and I kind of worked on all that together, and he was a fantastic person.
Not everybody likes this question, but I like it. So tell me a little bit about how you would like to be remembered.
I think I would like to be remembered for the people that I brought up, from my trainees and the people that my team. That for me, the success in what we do is the people around you and the people on your team. So I feel like my biggest success is that I've been able to help people rise up, and that's really how I would like to be remembered. I think if you should try to surround yourself with people that are better than you, and that brings up the whole team. And I feel like that's how I would like to be remembered, as someone who helped other people get to where they wanted to be.
That doesn't have to be more complicated than that. So tell me what your favorite surgical instrument is and why.
Yeah, that's a good question. I mean, it can only be one, right? I have three, but I think it's probably the Metzenbaum, because I really like doing meticulous dissection. And then with the Metzenbaum, you can do meticulous dissection, also blunt dissection. I love tissue planes, and for vaginal surgery, that's the tool. I mean, and so at the Dr. Nichols was the one that sort of was considered the father of vaginal surgery in this country way back when, and he has a lot of stuff about how to do vaginal dissection using a Metzenbaum and using your finger. And so I would say Metzenbaum, followed by the needlepoint Bovie, which I love.
Somebody said to me, I'm trying to think of who said it now, because now we've done a lot of interviews, but was that they didn't say it as their favorite instrument, but they said I should have said my finger, right? Because we do so much blunt dissection, right? But a lot of that blunt dissection though comes after meticulous sharp dissection.
So, although, I mean, there was one oncologist I worked with when I was a resident who he did the whole case with the Yankauer, just bluntly, but we had a couple of mishaps, with that. So, but I like fine dissection, and I love tissue planes, and for vaginal surgery, the Metzenbaum is the key.
Perfect.